Hello, everyone, and welcome to Talk with the Doc, the show where we bring your questions to Providence St. Joseph Health medical experts for insights and information. I'm your host, Mary Ranoff, and here with me today is Dr. Abershamian, an emergency medicine physician at Providence Little Company of Mary Medical Center. Today, we're answering your questions about what's the difference between an ER and an urgent care. Remember, everyone, all of your questions come from our listeners on social media. We can be found on Twitter at PSJH and on Facebook under Providence St. Joseph Health. Use the hashtag TalkWithTheDoc, that's hashtag TalkWithTheDoc, for the chance to hear your questions in an episode. Before we start, I want our listeners to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Okay, let's get started by welcoming our expert today. Thanks for joining us, Dr. Abershamian.
Thanks for having me back.
We're so excited. Well, today we are talking about ER versus urgent care and what's the difference. So, before we get started, tell us about your role here.
So my role here, I'm the attending physician at Little Company of Mary in Torrance. I work about 14 shifts a month or so, and then plus meetings. And I'm basically the quarterback when I'm in the ED, helping coordinate the patient care and their experience while they're in the emergency department.
And then all the radio shows and TV shows that we make you do.
Yeah, it's tough. It's tough, but somebody has to do it in the music festivals. And
right?
Yeah.
Well, that's funny. You actually do volunteer at music festivals, so you probably get kind of the craziest of crazy situations.
We do. We get to see the different drug trends and what the kids are doing and listening to. And I do have to clarify, it's not volunteer. I do get paid.
Oh, nice.
But I do it for the love.
For the love and for the music.
The love, the music, the experience.
Wonderful.
The vibe.
Well, we did ask people to send in their questions about when to use the ER or urgent care and really what the distinction is. And so I think the biggest question we got was deciding between urgent care and the ER. What's the difference and how do I make that decision?
So really good question. Whoever asked that, that's a fantastic question. Urgent care can handle basically complaints that don't need a very complex decision making and or advanced imaging. If you need a CAT scan, most urgent cares don't have that capability. If you need a complex ultrasound, a lot of urgent cares won't have that capability. And so if you cut yourself pretty straightforward during business hours or during the urgent cares hours, for sure. They can handle fractures, sprains, strains, travel medicine, things like getting immunized before you go to Africa or on any trip. They have tremendous capability. UTI, pregnancy tests, things like that. Once you need a certain level of imaging or an actual consultant to respond in real time, that might be a little trickier in the urgent care setting.
What's a complex ultrasound?
A complex ultrasound might be something like a pregnancy ultrasound to make sure pregnancies in the uterus versus outside the uterus in a dangerous place, like what we call a tubal pregnancy or ectopic pregnancy. An ultrasound that may need to diagnose something surgical like an appendicitis or gallbladder infection. And so different urgent cares have different capacities for those types of images. And so the level of care, although it might be great care, they just might not have that capability to do that imaging.
Now, some of the things you mentioned, though, like getting vaccinations before I go on a trip, wouldn't that be better with a primary care physician? I mean, why would I go to urgent care?
Urgent care, great question. It tends to be a convenience issue. I think for things like that, they have more and more capacity to do things like travel medicine or vaccines. But the reality of the fact is that you may not always be able to get an appointment the same day or within a week with your primary care doc. And you might have to pay for that convenience by going to an urgent care versus the copay of going to your primary care physician. So I think what you're paying for is access and ease of care.
I actually saw that Express Care, one of the Providence programs, actually offers like back to school physicals or sports physicals at the Express Care clinics.
Fantastic, as long as they're not coming to the ER for them. Right? I'm good with that.
Well, how do you know what the best place to go to is? Is there like a checklist that I should look at, a website to go to?
Unfortunately, there's no algorithm per se. That would be fantastic if there were a checklist. But if you think you have an immediate life-threatening or limb-threatening emergency, no-brainer. You have to call 911. If you need advice, sometimes you can call the number on the back of your insurance card, call your PCP, and get some guidance from them. But it's always
primary care physician, right?
Primary care physician, exactly. But when in doubt, I mean, you have to go to the emergency department if you really think you're having an emergency.
What you just said makes me wonder, how do I know if it's safe to drive myself or call an ambulance? What's like the checklist there?
if you're not sure if you're able to drive, maybe like other situations in life, probably don't drive.
Sure, makes sense. Okay, makes sense. We got a lot of really great questions. What's the average wait time in an ER?
Great question. I'm liking these questions. It really depends on which ER, which area you're in. If you're in a rural ER that sees maybe one patient an hour, you might not have to wait. If you're in a busy metropolitan area and it happens to be a day that there's a lot of sick patients, you might have to wait a few hours. So it's case by case. It really is.
And what if I'm waiting 2 hours and then another crisis comes in and then another crisis comes in? How do you prioritize people?
Unfortunately, having been on both sides of the coin, it's not like a restaurant where you put in your name and table opens up and you go in. You might get superseded by a stroke or a heart attack or a stab wound. And so if you're not waiting, or if you're waiting and you're not being seen, it's probably a good thing, meaning that, if you can wait, that's probably a good sign.
You're not dying.
You're not dying. And so it can be really, really frustrating, and I empathize with that, but you don't want to be the one being brought back.
Right. Well, and on the same side, I would much rather wait if I have an ear infection or something like that for somebody who may be having a stroke. I mean, I'm willing to wait.
Not rule of thumb, but if you're having to wait a few hours, it may or may not have been something that could have been handled by your primary care physician or at an urgent care.
Right. Well, as the chief of the team or the quarterback of the team, as we talked about, what do you want people to know before they come to an emergency department? Like, you're the person telling them right now via the radio. What do you want them to know?
Sick patient, an ER patient, somebody with an emergent medical condition. I think you should know that the staff that went into the work that day came in with the best of intentions. Mm-hmm. These are people who really care about you, care about your family, and care about your outcome and your health. And even though it might take some time, the reason it takes so long is because we have to be perfect every time, and we expect ourselves to be perfect, and society expects us to be perfect. And so we're going to rule out any life or limb-threatening condition, get you admitted if so, and get you home with a good plan of care. And so the resources and thought that goes into that can't be really understood by the layperson until you've been through that training or through a few ER shifts to really understand what goes in. But the overarching message would be that we care, and any emergent medical condition will get immediately seen and taken care of.
Oh, that's wonderful. Well, let's go back to the questions. If I go to the closest ER, but my doctor isn't a doctor in that facility and I get admitted, how do I get assigned to somebody?
Another great question. So the idea that your primary care physician or your PCP will admit you to the hospital if you're sick, if you have the flu or if you have pneumonia or if you have a stroke, those days tend to be, there's still some doctors who do that, but that era is kind of fading out. It's hard to balance a day of being in clinic and then going to the hospital and rounding just because of the volume of care. And so we have these docs or internists called hospitalists who are hospital-based and will cover patients who are being admitted by a certain physician. So Dr. Smith's doc is their PCP. And so Dr. Smith's patient goes to the ER and gets admitted. He might use the Providence hospitalist team or another hospitalist team. So also if you have a certain HMO, your HMO will have a physician there that will care for you in general.
Well, the next question says, I've always wondered if you have to do the paperwork first if you come in with a serious critical emergency.
Usually, unless it's imminently life-threatening, your paperwork will be filled out to get your demographic information and to get your insurance information and all the logistical things. And so that tends to be one of the first things to be done when you come in through triage.
Okay. Well, this is an interesting question. Do I get to see the doctor who treated me in the ER when I get released? So I guess that'd be like a return visit or something?
Sometimes if, let's say it's a Friday and we want someone to be rechecked by their primary care physician, but it's a 1 or 2 day recheck. So let's say it's a suture or laceration that we sewed up in the ER. For that, if we really want to make sure if it's something complex or needs a physician's eyes on it in 1 or 2 days, we say, look, if you can get in with your doctor, if they have Saturday or Sunday clinic, great. Urgent care, great. But if not, come back to the ER and we'll eyeball it again and just make sure it's not getting infected or that it's healing nicely. So in rare cases like that, sure. But in general, those are the exception, not the rule.
So if I come in and I like Dr. A, I can't make Dr. A my primary care physician.
I would worry. I would worry if you wanted to see an ER doctor in the ER, but as flattering as it may be from time to have someone request to see you, they'll end up seeing whoever's on call, or we'll have a social worker or one of our team members help provide local clinics or resources in the area for them to see.
Makes sense.
So that the emergent patients can get seen.
Makes sense. Well, this question we got many times. Why is my ER bill so expensive?
Another topic near and dear to my heart, both as a doc and as a consumer who has to buy insurance as well. When you go to the hospital, you will have an ER bill, and one of the ER bills will be from the facility, so it will be from the hospital which treated you, and then there will be professional fees. For example, that's my bill from the ER, from my billing group, who will bill for the ER service, and there might be other ones from like the radiology team, if you get an MRI or a CT or an ultrasound or an X-ray, and they'll have separate bills as well. And so it can be really overwhelming. No one teaches this in school or in college even. It's just kind of something you learn over time. And so, for example, my wife and I went to an out-of-town ER on vacation this summer near her family's house, and we got a bill from the ER group, which our insurance covered, and a bill from the hospital, which our insurance partially covered but left us with a remaining balance. And so it can be really overwhelming, and it's part of our healthcare system that needs to be addressed. But what you're paying for and why it's so expensive is the emergency department is staffed 24 hours a day, 7 days a week. It's not like a GI lab or a heart lab or an OR. We're there ready for anything. You fall and hit your head and have a hemorrhage in your brain, we're ready. You cut yourself, 2 a.m., we're ready. You stumble out of the bar, had a little bit too much to drink, we're ready to hydrate you and make sure you're okay. And so part of what you're paying for is a board-certified specialist to attend to you, a team of nurses ready to look after you, and a full complement of staff in the ED, radiology staff, techs to help, clean you up, everything. You're paying for that convenience to keep the lights on, to keep those people paid so that we're ready for you. So, as a consumer, it's a tough pill to swallow, but that's where those bills come from.
And you mentioned kind of the level of training that you have and how you're kind of prepared for anything. Talk a little bit about what education an ER doc has.
Great question. So after college, we go to medical school 4 years. And during our third or fourth year of medical school, we decide we want to be an emergency physician. So our fourth year of medical school, we apply to residencies or training programs. In emergency medicine, they tend to be 3 or 4 years. We do anywhere from 8 to 20 interviews all over the country. And then we go through a process called the match. The programs will rank the applicants in order that they want them to train with them. And we do the same. And on one day, we get an envelope with, you're going to Los Angeles or you're going to Cincinnati or you're going to Boston.
Having flashbacks to Rush Week in college right now.
I can tell you about that process too, maybe for another podcast. But yeah, it's a very rigorous process. We have to be board certified within a couple of years of finishing residency if we want to call ourselves board certified specialists. And every 10 years or so, we basically have to take recertification examinations with continuing medical education to make sure we're fresh and on top of our field.
And what does continuing medical education look like for you? Is it more kind of like treatments and diagnoses, technologies?
All the above. So we have to be able to basically deal with anything that comes in. So it can be dealing with certain new ultrasound techniques or sepsis guidelines or treatment modalities, like anything that comes up in the literature to make sure that we're up to date with evidence-based care.
And are you getting specific training for mental health diagnoses and how to handle it?
For sure. Absolutely. Whether it's medications, recognizing things that come up in the community, certain drugs that come up in their antidotes. So we have to be ready, for sure. And it's an ever-evolving field, so absolutely.
That's impressive. And who do you typically work side by side with in an ER?
So we'll have, at least in our emergency department, there's never any single coverage. So there's always other docs on board. As we're admitting anywhere from 20 to 30% of our patients, we're pretty close with the hospitalists or internists who will admit our patients on behalf of the primary care physicians. And so we have to have good relationships with them, with our consultants, with our cardiologists, orthopedists, ear, nose, and throat specialists, anything that comes in, we have to have their specialists dialed in to come help if it's something we can't handle or if they need to go to the OR.
Did you ever go upstairs and see a patient who's been admitted?
Absolutely. Just to check up on them. If it's, we obviously can't do it for all of our patients, but sometimes a patient will hit home for some reason and you'll really have a unique bond with them. And so before a shift or after a shift, we'll go and see how they're progressing and how they're doing. The other day, actually it was a few months ago now, I had a younger patient, less than 30. His wife was out of town, and he had this really atypical, very strange chest pain. He was a young guy, no medical issues. And basically he said, something's wrong in my chest. I feel weird being here, but I don't really know what's going on. Long story short, we did some advanced testing and he ended up on CT of the chest having something called an aortic dissection.
Oh, wow.
Something that, if not treated within a few hours, he would have easily died from. So he went to the OR with a doc actually from USC. We joked about the patient was a UCLA grad, so he asked for another surgeon first.
Go Bruins.
The doctor came to the bedside, fixed him, and just on the way to the OR, he goes, "This is pretty serious, huh?" And so I looked at him and said, "Yeah, there's a good chance you might not make it out of this surgery." So he went upstairs, thank God did well. And then a couple of days later, I went to visit him in the ICU. First thing he said, "Yep, I guess this was pretty serious." So it's always nice to see, the full circle of care.
Oh, that's amazing. Well, it shows that you have great compassion, so we appreciate that. So we're going to take a quick break, and when we come back, we'll continue talking about emergency department versus urgent care and when to make the decision.
Saturday night in the summer, sundown and they all come out. Lamborghinis and they rented hummus. The party's on, so they're heading downtown. Everybody's looking for a come up, and they wanna know what you're about. Me in the middle with the one I love it. We're just trying to figure everything out. We don't fit in well, 'cause we are just ourselves. I could use some help getting out of this conversation. You look stunning, dear, so don't ask that question here. This is my only fear, that we become beautiful people. Drop top designer clothes, front row fashion shows. What you do and who'd you know? Inside the world, beautiful people. Champagne and rolled up nose, prenups and broken homes. Surrounded but still alone. Let's leave the party. That's not who we are. We are not beautiful. Yeah, that's not who we are. We are not beautiful. True for hours last night and we made it nowhere. I see stars in your eyes when we're halfway there. I'm not fazed by all the lights and flashy cameras, 'cause with my arms around you, there's no need to care. We don't fit in well, we are just ourselves. I could use some help getting out of this conversation here. You look stunning, dear, so don't ask that question here. This is my only fear, that we become beautiful people. Top designer clothes, front row fashion shows. What you do and who'd you know? Inside the world, beautiful people. Champagne and rolled up nose, prenups and broken homes. Surrounded but still alone. Let's leave the party. That's not who we are. We are not beautiful. Yeah, that's not who we are. We are not beautiful. We are not beautiful.
We are back with Talk with the Doc, and today we're talking about the differences between the emergency department and urgent care. And we are going to play a fun little game with you, Dr. A.
Ready.
We're going to go rapid fire. I'm going to give you the condition. You're going to tell me whether it should be the emergency room or urgent care and why.
Okay.
You ready?
Is this binding?
It's not binding. Nobody's
Okay.
going to hold you to it.
Okay, fair enough.
All right. Ready. In 3, 2, 1. Cold or flu?
Cold or flu. So if you have a 90-year-old with influenza, low blood pressure, dehydrated, ER. If you're a healthy, 20 to 50 plus, no medical issues, you feel like you have the flu and you need a little IV or you need to confirm a diagnosis, urgent care is probably okay. Really depends on your vital signs and your comorbidities. Comorbidities being chronic medical issues, diabetes, blood pressure. So, yeah, it can go either way, but if you need an IV and you need fluids and you need lab work, probably the ER.
Okay. Nosebleed.
Nosebleed, if you're on blood thinners, older, high blood pressure, so if you have other things that need to be controlled, probably the ER. Otherwise, probably can be handled at home or urgent care if you really need. My tip for those, hold pressure right at the bridge of the nose, 15 minutes. Take off
15
pressure.
15 minutes. Okay.
Like stopwatch,
Yeah.
put an alarm, it has to be 15 minutes. People underestimate or overestimate how much time they've held pressure.
Sure.
15 minutes. Hold pressure. If you're bleeding, another 15 minutes. If you're still bleeding after that, then you need to seek medical attention.
Okay. Alexa, set a timer for 15 minutes.
There you go.
Perfect. All right. Broken bone.
Depending on how complex, so obviously if it's what we call an open fracture, you need to go to the emergency department.
That's like it's sticking out of the skin.
It's sticking out of the skin or you can see the bone, probably needs imminent surgery. That's a tough one, but if it's something that's pretty straightforward, you can probably do urgent care, but most broken bones, I wouldn't fault people for going to the emergency department.
All right. Next up, ear infection.
Ear infection can almost always go to urgent care.
Almost always.
So again, in the rare case, it's always a continuum. So in the rare case that it's what we call a malignant otitis or an ear infection that's actually migrated into the external part of the ear or the mastoid bone to the back of the head, those can be complex and need CAT scans and surgery. But for 95% of your ear infections, you can go to your primary care or urgent care.
All right. Chest pain.
I would err towards the emergency department if it's real chest pain. I'll probably get in trouble for saying urgent care on that one.
Yeah, I can see that. I think when in doubt, always anyway, right? Fever.
Fever, so if you have a 2-day-old neonate with fever, that's a medical emergency. That needs to come to the emergency department. It's a, 10-year-old healthy kid with an ear pain or fever, can probably go to their pediatrician or urgent care. But it really depends on the comorbidities like we talked about before. But fever is just such a broad thing that we see. That one's tough to tell. So you have to go case by case.
What if you said fever or temperature over 102, 103? Like, is there
so real temperature is a 100.4 Fahrenheit or higher, 38 Celsius or higher.
Okay.
So that's how we measure fever.
Okay.
Good question.
Difficulty breathing?
So if you're an asthmatic who has a known history of asthma and you're wheezing, you can probably go to PCP or urgent care. But if you're truly having air hunger, can't really breathe, you have to go to the emergency department.
All right. Dizzy or lightheadedness?
Pretty broad. That one's another one with comorbidities. If you just ran a marathon and you're lightheaded and you need some IV fluids because you're dehydrated, go to urgent care. Go to an IV drip center. If you're 90-year-old grandma's sensation that the room's spinning and she has a headache, and go to the emergency department.
I feel like you want to throw in common sense at the end of each one of these.
Can you tell?
Just a little.
Common sense is very helpful when deciding whether to go, but I don't blame the public for not knowing because this is not something that they deal with every day.
Can I call an emergency room and say, this is my symptom, should I come in?
Good question. Common sense would probably tell you yes, but we can't make diagnoses over the phone. Right. So in general, if you need to err on the side of caution, we're always open.
All right. Well, continuing the game, nausea.
Nausea, if you have home anti-nausea medication and it's not working, you can't keep anything down, you need to go and get some IV fluids or, have a CAT scan or abdominal ultrasound or evaluation. I would probably go to the emergency department.
What are anti-nausea over the counter?
Nothing really. You can try like ginger. There's some over-the-counter stuff, but we have some good prescription medications that can go either oral or IV.
Got it.
You can do those at urgent care as well. It just depends on your risk tolerance.
Sore throat?
Sore throat, uncomplicated sore throat can probably usually go to urgent care.
Okay. Bleeding.
from
So
where
vague.
from where there's so many permutations of bleeding. Is it pregnant vaginal bleeding? Is it nose bleeding? Is it rectal bleeding? It all depends on common sense and clinical impression. But, again, we take all comers in the ER, but if it seems pretty straightforward and can be managed by urgent care, you can always start there. They also don't hesitate to transfer people to the ER if needed.
Okay. How about burns?
Burns, we have a set of criteria for what warrants a burn center criteria or can be managed in the ER or needs to be managed in the ER. Common sense tends to, to weigh in, but when you've gotten a burn and you're in a lot of pain, that can all go out the door. So if it's an uncomplicated small area of a burn, you can probably start at urgent care. But if you're in a lot of pain and you need IV pain medication, or it's in an area like the abdomen or face or palms or soles, there's a lot of different complexities there. So we're all trained in burn management, and so I wouldn't blame you for going to the emergency department.
Can I digress for a second? Because I had this argument with a grandmother the other day that putting butter on a burn, she swears that putting butter on a burn is the best thing ever, and I'm convinced that that's wrong.
I've never seen or heard of that.
Really?
But I'll have to get back to you on the butter burn.
Okay. I'm pretty sure I've heard that my whole life. Okay. Let's go back. Rapid fire. Poisoning.
Poisoning, if it's a serious enough poisoning that you have to see a medical professional, I would personally go to an emergency department.
Right. Ooh, snake bite.
Where's a snake bite? What kind of snake? What are we talking about here?
Oh,
Is it an anaconda in the Brazilian rainforest?
Ooh, python?
Is it a python bite? They
What are
usually
the deadly
they're
ones?
more
Rattlesnake.
constrictors.
Rattlesnake.
Rattlesnake, yeah, you got to go to the ER. So there's different antivenoms. There's crotolid antivenom that, depending on what type of snakes live in that area, will carry the different antivenoms. So you have Elapidae and crotolid and all these different types of snakes. So, for example, we don't have sea snake antivenom because we really don't have sea snakes here. But I imagine in Australian or New Zealand EDs, they'd probably have those. And so we have different antivenom for different types of envenomations. But I wouldn't go to an urgent care for that.
Would that be the same answer for spider bites?
Spider bites, unless there's systemic toxicity or you're like having a fever, there's other symptoms other than where you got the bite, you could probably start at urgent care and go from there.
Just to see if you're listening, shark bite?
Shark bite, probably definitely primary care physician.
How about a panic attack or mental health crisis?
That was a joke, by the way. Don't sue me.
Panic attack, mental health crisis, which is also not funny.
It unfortunately depends on your access to care. So if you have a primary care who you have access to, who can immediately refer you to a mental health professional, I would go that route. Because when you're, having a mental health crisis, if it's a new crisis or an exacerbation of something that's already diagnosed or known, being in the stressful emergency department with all the unfamiliar sights and sounds and stress there can make people worse sometimes before they get better. And so I would avoid the emergency department at all costs, if possible, if you have access to a mental health professional as an outpatient. If you can't, go to, a facility that specializes or a specialist, then I would go to the emergency department. But as a last resort, unless you're a danger to yourself, danger to others, or gravely disabled.
All right. How about a cracked tooth?
Where do you think?
Dentist?
Yes. Yes. Not all dental injuries happen during dental hours or dentist hours. So after hours, if you can't get a hold of your dentist, urgent care, and if urgent care is closed, then I guess the last resort would be the emergency department if it's just an uncomplicated chipped tooth.
Well, the last one we have on here is woman in labor.
Definitely primary care physician's office for sure.
I don't believe you.
No, I don't know any urgent cares that do deliveries, and so every hospital should have someone on standby who has the capacity to deliver. So,
Well, that was fun.
That was really fun.
That
that's my first rapid fire.
We'll do this again sometime. Well, we still have more questions that came in. I think this one was interesting to me. Why is it faster to see a doctor when I go to urgent care?
So at urgent care, it tends to be faster because they're less busy and the nature of the visits are less complex. So if it's a laceration, you come in, get the wound cleaned out, get sutured up, and you're on your way plus minus some antibiotics and pain meds. In the emergency department, sometimes you'll need more than one imaging test. You'll need a consultant to come see you. And so the ED course can be a few hours versus just 1 hour or half an hour.
All right. Well, in the same vein, do urgent care centers generally cost less than emergency rooms?
It's really dependent on your insurance carrier, but in general, I think insurance will want to incentivize people to go to urgent care because there's not as much staffing, there's not as much complexity, they don't need to pay for all the imaging. It's just less. It's less there. And so sometimes if you can get what you need at an urgent care, it can be a more cost-effective option.
Well, we had another question that said, how do I know if my insurance covers an ER visit?
I'd like to answer that one. I'd like the answer to that one personally too, because it's really tough to tell what your bill will be, and it really depends on your insurance. It depends if you've met your deductible. What's your co-insurance? There's so many factors, and depending on where you are in your deductible, what insurance product you have, and whether your hospital's in network or not, your bill could be anything from $0 to several $1,000s. And so your best bet would be to either call the insurance company ahead of time and ask them, hey, I'm going to go to this hospital for this test or for this, what are my options? Are there other places that are in network in the area? Or what will my bill be if X, Y, Z? And they can, depending on how helpful they are, kind of help break it down for you. But in general, it's tough to tell how much, depending on which insurance you have.
Well, if I'm driving myself, I can pick which emergency room I go to, although theoretically I'd go to the closest.
Correct.
If I'm in an ambulance, can I tell them which emergency room I want to go to?
So if you live in an area that has equal access or, is proximal to a couple different hospitals, if all of your care is at one hospital, you can request, I'd like to go to this hospital, all my specialists are there, all my records are there. So that's certainly, it never hurts to ask. But sometimes, depending on the nature of your emergency or how far away the hospital is, or, there's multiple factors, but you can always request.
Well, this question, I really am interested in hearing the answer. What if I'm afraid to go to the ER because I don't feel safe there?
Safe in what sense?
Well, I don't know because the question came in, but I'm going to guess maybe that they're worried that it's a violent area.
So we always have security on standby in the emergency department. We have multiple security guards. So I think the staff is probably at more risk than the patients. I haven't personally really ever seen any patients get violated or personally assaulted or anything like that. And so we always look out for patient safety from the triage process all the way through to make sure it's a safe environment for them.
Thank you, Dr. Abershamian, for joining us today on Talk with a Doc, and to everyone for listening and sending in your questions. We look forward to a future topic with more experts from Providence St. Joseph Health. Make sure to follow us on social media at PSJH on Twitter and on Instagram, and under Providence St. Joseph Health on Facebook. To learn more about our mission, programs, and services, go to future.psjhealth.org. Thanks for listening.